for joining us for today's webinar. By the way, my name is Jaisal, your host for today. And today we are presenting Up Your AMD Game, The Power of Genomics to Improve Outcomes, presented by Dr. Pamela Lowe. And just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the question box in your Zoom panel. We'll collect them and bring them up after the presentation since we will also have time for questions at the end. All right? I would now like to introduce our speaker for today. She is a diplomate of the American Board of Optometry. She is also the director of the Professional Eye Care Center Incorporated and also a medical director of Vision Source in Chicago. Now, without further ado, we will turn the time over to Dr. Pamela Lowe.
Thank you so much. Let me just share my screen here. There we go. Well, it's wonderful to be with everyone today, especially talking about a paradigm shift in the way we look at early detection for our macular degeneration patients at risk. And so I urge all of us today to really, let's advance here. There we go. To really think about this talk, I want you to take two words away with you: opportunity and empower. And we'll weave that into the discussion as we go through. But there's never been a greater opportunity to help our patients with visual outcomes, especially those at risk for macular degeneration. These are just my disclosures. I either are on advisory boards or speaker bureaus for the following companies. But this is really what is so key to the opportunity we're going to talk about today. And you look at the American population and how baby boomers are getting older and living longer. And if you just look at this graph, you could see the trends. That's what I want you to look at. So what we're looking at in today's world is what's called the silver tsunami. And if you look at those of us that are aging, and baby boomers were born from 1946 to 1964, I'm the tail end of that, so I'm in that group. And we're all getting older, living longer, having advanced careers, or retiring early, but have a lot of visual needs. And if you look at these trends at the younger folks in the US, and you take that out over the next 15 years, the 0 to 19-year-olds, the 20 to 34-year-olds, those lines are flat, but you can see the two that are growing are those 35 to 64 years old and those greater than 65. So just super compelling. So talk about presbyopia. In fact, we know presbyopic patients are at risk when they're 40 and older. And the oldest millennial, so those are the folks born from 1980 to 1996, or 1981, 1986. The oldest one just turned 40, guys. So our millennials are aging rapidly with us. So this silver tsunami is huge. And when we look at the numbers, we know AMD is the leading cause of vision loss for everyone over 60, in America. In the world, when you're 50 and older, you're looking at irreversible blindness risk from that. And then you can just see the numbers here. As many as 11 million Americans have some level of AMD, and that's expected to double just over the next couple decades. And as primary care providers and our ophthalmology colleagues, we're also worried always about those leading causes of vision loss, right? Glaucoma, diabetic retinopathy. But if you look at those at risk for AMD, and you add up from vision loss from AMD, and you add up those at risk at vision loss from glaucoma and diabetic retinopathy, it doesn't even equal the numbers of those of our patients that are at risk from vision loss from AMD. So let's look at the pie, and we take, all the things that we worry about with our patients, cataracts, diabetic retinopathy, glaucoma, and look at the piece of the pie and how AMD just takes up well over 50% of that pie. As we said, we have an aging population in the US that's living longer, more dynamic visually. They need that vision to live, at the highest level. And we know that AMD is not only, our patients here in America at risk, but it affects everyone globally. And the risk of central vision loss is what is just so awful for patients as they get into that aging population. And you can see the numbers here. Approximately 15% have central vision loss between 65 and 75. And then as they get older, that doubles. And there's a cost to losing vision, right, on the healthcare system. So greater than $5 billion. So just look at that all the way around. And we could see here from the graph that those at risk for intermediate AMD or have intermediate AMD are at risk for later AMD or advanced AMD and vision loss, and that increases dramatically as we age. But the other key thing, it's not only time is that risk factor, it's the genetic roll of the dice. That's a huge risk factor as well. So again, you could see on the graph here, if we take our population of those 50 and older, and we look at that as they age, the general population has a risk about 10% of going on to vision loss by the time they're 80. That risk increases. But if you have a first-degree relative with a history of AMD, your risk is even greater, dramatically greater. So when we look at a disease that over 70% has a genetic cause, and we compare that to other diseases that we worry about with our patients, right? Because we know obesity is a risk factor for AMD, cardiovascular disease is a risk factor for AMD. And then we look at all the other things that can happen to us with cancers and diabetes. Just look at that comparison. AMD has the highest level of genetic cause. So do we know enough about the actual genetic roll of the dice for our patients? And we do know that AMD, we can identify your genetic risk of AMD by certain SNPs that we find that you have in your gene pool. And if you look here at this graph, CFH gene is one of those ones, and along with ARMS2, that puts you at higher risk for going on to vision loss from AMD. And we can ask our patients, hey, do you have a family history of AMD? And we always check that box. But what does that really mean? So if you look here, I love this graphic because you could see you have a mother and a father who might have, and they might carry a neutral risk and genes for a higher risk. But what did the child actually inherit? And the good news is that 25% may inherit a lower genetic risk than their parents. Unfortunately, 25% may get a higher genetic risk than their parents, but 50% are going to be in that kind of middle of the road. And as a primary care doctor who is doing their best of a lifetime of great vision for our patients, right? At my primary care practice, we see from cradle to coffin, and my patients are aging with me because I'm the senior doctor in the practice. What does that actually look like? Are we just checking the box that you have a family history, but did you get the lower genetic risk or did you get the higher genetic risk? And that's what's so key, and that is the empowerment of taking genetic testing, because look at what patients are at risk for getting AMD. And in optometry, we know we're great at talking about UV exposure. We're very good at talking about smoking. All of us healthcare professionals are good at talking to our patients about smoking and the risks of not only vision loss, but what that can do to the body. But are we doing enough when we talk to our patients about excessive weight they might have, lack of physical activity, what they put in their body and how they move their body? Are we having those discussions, especially when we know that their genetic roll of the dice is putting that at a higher risk? It's so important that we're talking about all those other modifiable risk factors that we can. Because we know that since AREDS 2 came out, there's been many studies that tell us that earlier supplementation with nutraceuticals can improve outcomes. And you can just see here when we're looking at just having a better diet. So you get omega-3s in your diet. You could see that gives you a dramatic reduction in your risk for going on to AMD, along with taking into account lutein and zeaxanthin decrease the risk, as well as vitamin C. So we know that AREDS showed us that there was a reduced risk, and there's been many studies since then that really show that if we're intervening early with nutraceuticals, that could definitely benefit patients. And when we look at visual outcomes, we know it's so important to identify our patients at risk because we need to have a timely referral, especially if they're going on to choroidal neovascularization. So we know wet AMD, if patients are converting from dry to wet, we want to get them to retina as soon as possible. And like with any condition, if we diagnose it early, the outcomes are better. So you can see here, if there's a delay in treatment because we may not be monitoring our patients as closely and waiting for them to have symptoms, we're really missing the boat on improving outcomes. And we know we have so many more tools in our in our toolkit now than we had years ago. I graduated in the end of the 80s, and these devices did not even exist. So we have dark adaptation now that can pick up macular degeneration subclinically before the patient has structure or function loss. We measure macular pigment optical density on our patients. Everyone 18 and older gets that measured because we want to identify, do they have low pigment in their macula that's protecting it? And we want to identify that early on so we can educate our patients about how they move their body and what they eat to, again, get them early and help on the back end. And we know OCT has just been a game changer for us with being able to see what we need to see below the surface of the retina. But what's key in dark adaptation is that's picking up subclinical AMD before we see those structure changes even on our OCTs. And then we know once we identify a patient at risk, we have home monitoring systems you can see here that are much better than just handing them an Amsler grid and saying, let me know when you see a wavy lines. So we have, again, better ways of monitoring our patients and tracking them for progression. And that's where the empowerment comes in with visual genomics and measuring actually the patient's genetic risk of going on to get AMD. It's a simple test. We're all familiar, the world is familiar with genetic testing. It's a simple swab test that lets us have a lot of information so that we can better manage our patients. So what happens is it's a great system where a patient will give their genetic sample. It's going to give us their panel, their SNP panel. It'll give us a severity score grading. We actually, when you send the test in, you fill out a questionnaire giving the patient's history. So we know, are they smokers? Do they have a high BMI? Are they educated? We want to get those demographic and lifestyle characteristics in there. And then it has an artificial intelligence that takes all that information along with the genetic roll of the dice and lets us know exactly what the patient's risks are. So there's two different tests that are available. We have one that we kind of key in a lifetime risk assessment for our folks who don't have any changes, they don't have any structure changes, they're under 55, but they may have risk factors, smoking, family history, other at-risk behavior. So we have a test that will give us what their lifetime risk is for that. And then I'm using mostly the progression risk assessment, having older patients who are over 55, whether they have clinical findings significant for AMD or not. A patient at risk, it's great to know over 2, 5, 10, 20, and 30 years, what is their actual chance of going on to vision loss? And how awesome is that for me to be able to know that? So I know in a timely way how to set up the patient's further protocol for catching them early. And right now we know that we're catching AMD way later. Any retinal colleagues that are on the talk today, you're getting those folks sometimes way later. And if we can get them at the very beginning of any conversion, it's just so important for better outcomes. So today in the US, with this growing population, and all of medicine going to personalized risk, it's so key to have that early identification and now have a simple, affordable genetic test that can really help with a personalized treatment plan for a patient. And again, the whole goal is to prevent vision loss and improve outcomes. And I always say what's great for patient care is great for our practices as well. So when we're seeing a primary eye care patient, there's many things we can do. We have wellness OCTs we can run. We have genetic testing now when they have a family history. We love our dark adaptation testing because it's picking up, up to 3 years before a patient has a structure or function loss. We're able to tell if the patient's at risk. And then, of course, better ways of monitoring their contrast sensitivity because we know AMD will reduce contrast sensitivity, and then monitoring the structure, of course, with our imaging systems, fundus photography, autofluorescence, along with OCT. And when you identify the patients at higher risk, how awesome is it now we can set up a treatment plan because I know 2, 5, 10, 20, 30 years out what their risks are. I could set up an appropriate treatment plan for that patient. And again, if I start seeing structure changes or advancing, we're going to increase the frequency of the visits. we're going to utilize everything in our toolkit to watch them more closely. And then if they do convert, obviously a timely referral to our retinal colleagues. And I can't tell you how much this has helped just not only educate our patients about what they're at risk for, but really when you have an educated patient, they love to tell other friends and family about what their experience was. And we get so many referrals because we do go that extra mile when it comes to finding those at risk for AMD. And one of the great things about genetic testing, it's accessible, it's affordable, and there's ways that patients have, if they're working, that can help their flexible spending accounts, their health savings accounts can kick in, because this is medical necessary testing to find out who may be at risk. And the company, Visible Genomics, is doing a great job at helping you as a practitioner have ways you can get your message out, be it social media, which is huge for most practices now, email blasts, posts wherever you feel it's appropriate on blogs or your website. So really getting that buzz around genetic testing and how it's so important for visual outcomes has been much easier than in the past. So as we close here, before we take questions, I wanted to just go over a couple of cases that I've recently had that really help drive home how we position genetic testing in our practice. In this first case, both of them are 66-year-old and Caucasian. One's a male, one's a female. Both are higher myopes. But this first case is actually a patient that lives in California, who became a patient, I should say. One of our longtime patients moved to California, was a long time in our practice, knows we love being cutting edge, and actually told his friend in California about how we handle AMD and that there's a genetic test available, because this patient called and reached out because their dad had vision loss from AMD in his 70s. His dad was a construction worker who never wore sunglasses. So, he wasn't sure, did my dad get AMD? Because he heard that UV light can have an impact, and it certainly does. Or is it genetically something he can inherit? Because his brother called him and said, oh my gosh, I was at my eye doctor and they said I have dry AMD. He knows his dad went on to vision loss with wet AMD, and now his brother, who's almost 70, the same thing. So again, a patient who's very, very worried because he does have a history of coronary heart disease. You can see here he has AFib, he has a back condition. Those are the medications that he's taking. So we were able to send him a genetic test, and once we got the results, we were able to actually go over a treatment plan. Even though he's not a patient here in Chicago, we were able to instruct him what the treatment plan would look like in our practice and how he can seek that care out in California. His results came back, as you can see here, moderate risk. So he's 66 years old, and these are your risks for vision loss, going on to vision loss from AMD. So you can see the risk is low in the 2 to 5, even 10 years, but definitely increases 20, 30 years out. And so we went over those numbers in a telehealth call, and he actually was super relieved because he's like, I'm 66, I don't plan on living 30 more years. I see my risk is a little over 10% for the amount of time I plan on being, or I think I'm going to be around. So our treatment plan was obviously continue your heart healthy diet. He is on blood thinners, so we caution him about spinach intake. Continue moderate exercise, and he has back issues, so we discussed strategies for what moderate exercise would look for him to protect his back, but he had never heard about carotenoid therapy. And per his history, he has no structure or function loss. So now that I know his genetic roll of the dice is moderate, we definitely want to get him on a nutraceutical. And I told him about a way he can be monitored better by finding a practitioner that can help him with dark adaptation. So, really, really put this patient's mind at ease. We know what we're dealing with now, and we can set an appropriate treatment plan. He's actually retired early and has been retired at 62. So again, he's active, and we want to keep this patient seeing well. Our second patient is also 66 years old. Like I said, a higher myope, no structure or function loss so far, but she has noticed a change in her night perception. And that's key. We have started asking all our patients, especially 50 and older, do you notice a change when you go from light to dark? because we know with early AMD that can be the first symptoms well before years before they have any loss of their 20/20 vision. You can see here she has hypertension, osteoporosis. She does have a bilateral ptosis, so she is actually on an upneak, which is that drop that raises the lid when she wants that. She's a longtime rigid gas perm wearer, so we know those folks, years of wearing rigid gas perms, they'll get the bilateral ptosis, and her upneak really helps her with that. And you can see here she's on Fosamax and losartan. Her father became a patient in our practice, and he already had dry AMD. He came to us when he was 92, and he had pretty decent vision still. And we had genetic testing. Actually, he came in when he was 90, and at 92, that was his best vision. But we did a genetic test when he was 90, and it showed a risk, as you could see here. Now, the genetic tests we had at the time gave 2, 5, and 10-year progression. So again, you could see that the risk goes up as he got older, and this was our patient's results from her genetic test. And again, you could see here, within the next 10 years, the risk of progression to vision loss is pretty low, but she's moderate risk because as she ages, that goes up higher. So our treatment plan with this patient, we're going to continue a healthy diet, control her hypertension. We obviously talked about how she moves her body, and then again, before structure and function loss, we initiate nutraceuticals to help protect that macula. And now we have her on regular dark adaptation and regular OCT testing to make sure if she converts that we're catching that very early. So again, the opportunity to improve outcomes for macular degeneration has never been greater when we have this silver tsunami of folks at risk. The opportunity to take advantage of genetic testing is key in improving those outcomes, and it really empowers us as practitioners to do a better job for our patients. So at this point, I'd like to take any questions. My email is there, so please note that, and I'm always happy to answer any questions now or if you have questions later.
Thank you very much, Dr. Lowe. Now we would love to hear from our attendees. If you have any questions, please feel free to type it in the Q&A box on your Zoom control panel. I guess you have a question here, Dr. Lowe.
Great.
All right. Question: how does the patient receive the test results? Do you review in person or via telehealth?
Yeah, that's a great point. So once the genetic test is taken, the patient does not get the results. The doctor directly gets the results. And then that's the opportunity for the doctor to go over the results with the patient, either in person or by telehealth. Obviously, that one patient I gave an example of didn't even live in the States, so we did a telehealth visit on him. But it's been great, especially the older my patients are, instead of having them come in for another visit just to go over the genetic results. It's great to be able to do a telehealth visit, but certainly in person always works well too, especially if we want to run other tests in a more timely fashion. Then we'll go over the genetic results with them at that time and run any additional clinical tests.
All right, thank you. Now we have another question from Delia. How does the ophthalmology community in your area respond to your treatment and referrals based on genetic testing?
Yeah, great point. So I have a very tight relationship with my retina specialist for 30 years now. And they are great. We have a very open line of communication, and I urge everyone to have an open line of communication with whatever ophthalmological colleague they deal with. That's so important for better patient care and outcomes. They know we genetic test, they know we identify early, and my retina colleagues love it because we are better at referring when it's absolutely needed. And any retina specialist will know, anyone in eye care knows that retina offices are super busy and they're giving injections left and right. And they want to see patients that actually need their care. So because we are tracking our patients more closely, we're delaying onset of conditions, which improves outcomes, and we're getting them to the ophthalmologist with accurate and timely diagnosis. So yeah, they're definitely on board with that.
Right. Thank you, doctor. We have another question from Shannon. Okay, what type of supplement do you put your patients on if their non-exudative ARMD is moderate? And what's your treatment plan?
Yeah, so if they have structure changes, I'm going to put them on an AREDS type of formula. But there's been a lot of studies since AREDS came out. So I kind of use a formula that is based on AREDS, but has a little bit more in it that I feel is going to help my patient. But it's so key to talk to them about how they move their body. And obviously, the older we get, the risk of vision loss gets greater with each decade that goes by, and our bodies get a little bit slower. And there was a study that showed folks with intermediate AMD or vision loss in one eye, if they walked as little as 4 city blocks a day, that it reduced their risk by, I think it was close to 35% of getting vision loss in the fellow eye. And that's not hard to do. Walking 4 city blocks a day is not hard even for us as we age, obviously if the patient has other issues. But I talk to them about what they put in their body, how they move their body, and definitely get them on a nutraceutical. But it's a multi-pronged approach. We can't just throw nutraceuticals at folks and say, oh, you're going to be better. They need to eat better, and they need to have moderate exercise as well. There are a multitude of formulas out there now. A lot of good choices. So if you'd like to email me, if we could put that in the Q&A or in the chat so folks have that as well. Love to get more of a deeper dive. But that could be a whole 2-hour lecture on nutraceuticals.
Okay, thank you, doctor. Another question here. What studies have the best support for carotenoid therapy?
Yeah, so there's been a fair amount of studies. We know carotenoid therapy, when we improve the macular pigment, we know that it's protecting the macula, but it's also improving performance. So actually, we talk about carotenoid therapy with all adults. Kids are growing up with screens in their faces, and we don't know the long-term effects of that. And there have been studies that show that lutein and zeaxanthin not only protect your macula, but improve cognitive function in old and young. And so it has multiple benefits, but we know if we can improve the eye's protective pigments with lutein and zeaxanthin and the xanthophylls, we know that we're giving a patient more of a fighting chance. And there was a study, it was out east, and I'm sorry, again, if you email me, I can get the study to folks, but it was a doctor out there was really tracking his patients, and he was using early carotenoid therapy, and he actually was seeing structure improvement along with function improvement. And we run dark adaptation testing and OCTs religiously on all our high-risk patients. And it's really interesting. The younger I get a patient on carotenoid therapy who has just just moderate structure changes, we've actually have seen improvements. So, there's still a lot to learn out there, but, when you have a therapy that has 0 side effects for a patient, and can only benefit not only their eyes, but other cognitive brain function, that's a great treatment to have.
Okay. And a question from Richard. How does the patient obtain the test? Do you collect the sample in the office? Does the patient get the test shipped to them? And what is the financial piece for the practice?
Yeah, great point. So all of the above. So you could either do it right in the practice. The thing with a genetics test with this, it's a swab taken along the gum line, is you cannot have anything but water or black coffee within a half hour of taking the test. So we carry kits in our practice, but we also can ship kits to patients or give them the kit in the practice and they can go home later. I will tell you, in a busy primary care practice, sometimes we don't have time to do it in the moment. It depends if I have a tech available. So what's really nice is if you want to keep test kits in your office, that's great because they're handy and you can either do it right then and there, or the patient can take it home and send it in on their own. Or if you don't want to have any hassle of carrying an inventory, you can just have the test sent to them. You register the patient onto the portal and the test would be sent directly to them, and you'd be notified when the test arrives back and, of course, of the results. The cost component. Costs, you can set that for yourselves. The Visible folks can get back to you on how that can be structured. We, in our office, the test runs in the $250 range. So pretty affordable for most patients. What's cool about genetic testing is it's a one and done. So it's not like, oh, you have to retest again, right? Your genes don't change. And so it's a very affordable way for a patient to know their genetic roll of the dice and have that critical information. And again, so that structure, our practice most practices are making between $75 and $100 on the test, I would say, on average.
Thanks, doctor. And another question from Catherine. What's the turnaround time for results of testing?
Yeah, so that's a great point. The turnaround time is pretty quick. I mean, we've noticed it's within a 2-week range. So sometimes what's actually been taking longer is when we do give the kit to the patient and we can't do it right in the practice. Sometimes they have a little delayed time getting it in, but it's a pretty quick turnaround, which is nice.
And another question here. Do you feel dark adaptation testing is supported by both the ophthalmology and optometry community?
Yeah, that's a great question. Well, the science is there for both ophthalmology and optometry to see. The All-Star study proved that dark adaptation is not a risk factor for AMD. It's a biomarker for AMD with over 90% sensitivity and specificity. So it's been good science behind that, and that's up to 3 years before our OCTs or our exams are picking up structure or function loss. So subclinical AMD is a whole nother part of our continuum of you either have no AMD, early AMD, that's where you have structure changes. Now we have subclinical, where there's no structure or function loss other than reduced dark adaptation or impaired rod intercept time. So we find that I could not practice without that now, and most of you may have heard the company that is the leader in that, Macular, actually just switched hands, and a new company just took up the technology because it's so great. But yeah, I don't know how either ophthalmology or optometry could refute the science behind it.
All right, and another follow-up question. Do you believe that carotenoid therapy should include mesozeaxanthin?
So carotenoid therapy, yeah, I mean, there can be a whole discussion on that. There's great options. So the question, lutein and zeaxanthin are the main carotenoids that we know traditionally and that are in the AREDS formula. And then there's mesozeaxanthin. There's two camps of thought on that. My philosophy on it is you need to use carotenoids. So whatever you feel as a practitioner with the studies you're reading and what you feel is good for your patient, have at it. But the main thing is that you're using carotenoids.
Okay. And is this testing available in Canada?
You know what? I do not know that. The Visible folks will have to answer that. That's a great question. I'm not quite sure, since I do have Canadian colleagues that I know well, but I've never asked them that.
Okay. We have a message from Andrew. Thank you for the invite and information, and looking forward to working with you.
Great.
All right. Are there any more questions? Please feel free to type in the Q&A box. Well, I guess that's all we got.
Awesome. So remember, my first initial, last name, PLow@proeyecarecenter.com. Please feel free to email me anytime if you have any other further questions, and I'm sure the Visible Genomics folks will keep in touch with all of you and for any other further questions you have on specifics for them.
All right. Thank you so much for your time, Dr. Lowe, and thank you for joining Visible Genomics to discuss IMD testing. We appreciate you all signing in and hoping you have a great day. Thank you very much.
Thank you.